Welcome to this medicine masterclass in which we'll be discussing venous thromboembolic disease, case presentations and investigations. Venous thromboembolic disease may present as a DVT, a deep venous thrombosis in the legs, or as a pulmonary embolus in the lungs. A DVT would present with ipsilateral leg pain, swelling, tenderness, with subsequent discoloration and pitting edema, as shown in this image here. A pulmonary embolus would present with the patient reporting shortness of breath, cough, pleuritic chest pain with hemoptysis, tachycardia, hypotension in extremis, and a low-grade pyrexia. In some cases, these symptoms can be absent and the patient can have a pulmonary embolus. These conditions, if left untreated, can cause sequelae. DVTs can lead to post-thrombotic syndrome. This is where the leg, which is already edematous, develops venous eczema and venous changes. The leg discolors and has a brownish discoloration as a result of hemosiderin deposition as well as lipodermatosclerosis. Subsequent ulceration, itchiness, heaviness and pain can develop, which can become unsightly and uncomfortable to the patient. If PEs are left untreated, the patient can develop chronic thromboembolic pulmonary hypertension. The raised pulmonary hypertension can advance, causing shortness of breath, exertional dyspnea, and subsequent heart failure, and such patients require lifelong anticoagulation as the risk of recurrent PEs is significantly higher in these patient populations. There are various important diagnostic tests. For both DVTs and PEs and for thromboembolism, a D-dimer is a useful screening tool. We use the 2 levels DVT well scoring system to help determine the risk of DVT in patients, and a 2 levels PE well score for determining the risk of a pulmonary embolus. DVTs can be diagnosed with diagnostic Doppler ultrasonography or contrast venography, and PEs can be diagnosed with a CT pulmonary angiogram or a ventilation perfusion nuclear scan. The 2 levels well score helps determine the clinical probability which can stratify patients into different risk categories. This helps ensure that the most appropriate diagnostic pathway and treatment pathways can be instituted. The well score essentially is a score for clinical prediction to help rule out a DVT or a PE. The original 2 well score, compiled by Wells et al. In 1997, developed a 9-component clinical prediction rule for DVT. 2 points were deducted if an alternative diagnosis to DVT was at least as likely, and therefore the range was -2 to 8. The 3 possibilities were patients were high risk for DVT with 3 points or more, intermediate or low risk. In 2003, Wells et al. Revised this score, and this was because clinicians were essentially following uniform pathways with high risk and low risk patients, but there was heterogeneity with management of the intermediate population. The 2003 revision led to dichotomizing patients as either likely to have DVT or unlikely, depending on whether they had 2 points or more. An additional category was added of risk post-surgery from 4 weeks to 12 weeks, giving a possible score of -2 to 9. The 2 levels PE score, originally devised in 1998 and subsequently revised in 2000, helps categorize patients as high risk for PE with a well score of more than 4 points and unlikely to have a PE with a well score of 4 points or less. The 2-level well score for DVT patient scores 1 point for active cancer or treatment ongoing within 6 months or palliative, 1 point for paralysis, paresis or recent plaster immobilization of the lower limbs, a point for whether the patient has been recently bedridden for 3 days or more or has had major surgery within 12 weeks requiring general or regional anesthesia. A point is scored for localized tenderness along the distribution of the deep venous system, a point if the entire leg is swollen, a point if the calf is swollen more than 3 centimeters larger than the asymptomatic side, a point for pitting edema confined to the symptomatic leg, and a point for collateral superficial veins. A point is also scored if the patient has had a previous DVT, and 2 points are subtracted if an alternative diagnosis is at least as likely as a DVT. 2 points or more in this system would indicate a likely probability of a DVT, and 1 point or less would suggest the DVT is unlikely. The 2-level Wells score for PE, patients score 3 points if there are clinical signs and symptoms of a DVT, that's a minimum of leg swelling and pain with palpation of the deep veins. 3 points if an alternative diagnosis is less likely than a PE. Patients score 1.5 points for tachycardia, a heart rate of more than 100 beats, and 1.5 points for whether the patient has been immobilized for more than 3 days or has had surgery in the previous 4 weeks. Patients also score 1.5 points for a previous DVT or PE, and 1 point for hemoptysis and 1 point for malignancy, whether they're on treatment or being treated in the last 6 months or whether they're palliative. The scores are added up, and a PE is deemed likely if the patient scores 4 points or more. A PE is unlikely if 4 points or less are scored. Thank you for attending this medicine masterclass.